On behalf of the IRPP, I want to thank you for joining us in this first of 4 webinars on long-term care reform that we'll be hosting in coming weeks. These events also coincide with the publication of a series of policy options articles beginning next Monday on May 17. Our objective with these events is to examine the reasons for government's failures to address the systemic problems in long-term care and to start a conversation on how to best tackle these problems. In this first webinar, we want to be resolutely forward-looking. It's now widely acknowledged that the gaps and failures in long-term care largely predate the pandemic and that fundamental reforms are long overdue. What we would like to do today is what we would like to do today is to identify the biggest obstacles to reform and begin to outline the key policy priorities and propose a path forward. There are a wide range of proposals for change out there, including new infrastructure, better regulation, monitoring and accountability, increasing staffing, better pay and work conditions for personal support workers. But where do we start? Who should assume the needed leadership? How do we ensure that our governments keep long-term care reform near the top of their post-pandemic agenda? We are fortunate to have with us today 3 panelists whose expertise and knowledge in these matters are ideally suited to guide us in this conversation. Tamara Daly is a political economist, health service researcher, and professor at York University and director at the Center of Aging Research and Education. André Picard is a health reporter and columnist for the Globe and Mail. He is the author of 5 best-selling books, and including his latest, Neglected No More, The Urgent Need to Improve the Lives of Canada's Elders in the Wake of a Pandemic. Dr. Samir Sinha is the Director of Geriatrics for the Sinai Health System and University Health Network. He is Associate Professor at the University of Toronto and the Johns Hopkins University School of Medicine, and Director of Health Policy Research for the National Institute on Aging at Ryerson. I would invite you, to our audience, to send their questions in the Q&A, but we ask you to make these questions concise and to the point. We'll try to get to as many of them as we can, but we have record numbers in attendance today, and unfortunately, only an hour at our disposal. So let's get to it. I invite our panelists to open their mics and their cameras. We will begin with introductory remarks by each of our guests and then proceed with our conversation. And so we'll begin with Tamara Daly. Tamara.
Hello, thank you IRPP for hosting this webinar and inviting me to it. Let me start by saying that long-term care is a wicked policy problem that governments have not gotten right, even looking back 80 years. In part, this is because the responsibility for long-term care is diffuse. It's a sector that should, but often does not cross ministries of health, social care, disability, housing, recreation, and labor. It involves multiple levels of government. What is more, it sits outside of the Canada Health Act as an extended service, and it is not subject to its 5 principles. It separates funding from delivery, administration, and accountability. And it's delivered by a range of private and public actors, professionals and non-professionals, as well as permanent and agency staff, families, volunteers, students, and contractors. This diffuse responsibility has made it easier for governments to shift the blame to long-term care homes and to individual workers when things go wrong, even when the spotlight should be on the policy level. COVID exposed this vicious policy cycle of cost and blame shifting. It revealed the underinvestment, understaffing, undervaluing, poor oversight, and the rigid policy systems we've designed that often produce mediocrity and even let the bad apples continue to operate. Don't get me wrong, we have some excellent homes in this country, and both here and abroad, colleagues and I have done a significant amount of work and case study work with these innovators. But I would argue that these homes are excellent despite the system and not because of it. So to get to a virtuous cycle, we need to follow a different roadmap. First, I think we need a destination in the form of national principles for seniors care that reflect on the values we share and that harness the federal spending power. National standards are fine for the organizational level if they establish guidelines but resist standardization, such as with mealtimes mandated at exactly 8 a.m., noon, and 5 p.m., or fixed counter heights in washrooms that don't imagine how we might install ones that can move up and down. We can build on Canada Health Act principles, but we need new ones for seniors care that reflect how long-term care is part of seniors care, and it includes but extends beyond healthcare. Second, we're on this trip together. The principles must build on the bedrock of our shared risk and responsibilities toward one another. No one asks to get dementia or Alzheimer's, multiple sclerosis, or Parkinson's, but these diseases can outstrip the capacity of even the most well-resourced of families to provide care. I've been in a home with a former star hockey player whose family needed long-term care, despite their wealth and because of his size, strength, and the progression of his disease. This is why we must have a high-quality long-term care system that reflects our interdependence, removes stigma from families who need it, supports a good quality of life for a person in late life, and good working conditions for carers. Third, we need to gauge our progress. The system requires public accountability with more robust and timely public reporting of data, and a bar set at excellence and innovation, not mediocrity. Here, I'm not talking about a technocratic endeavor or one that only prioritizes medical outcomes, but robust facility-level data that are publicly reported, are comparative and longitudinal, report funding levels, and that show performance on staffing outcomes, quality of life outcomes, community engagement, improvement, and innovation. How do we capture the brilliance of putting an inoperable van in the backyard of a home with a former mechanic so he can tinker with it, and so future residents might enjoy car washes as a summer activity? I'm advocating for a type of facility-level data that requires the input of medicine, but goes far beyond it, importantly including the social sciences and humanities approaches and qualitative data in ways that allow us to imagine aging differently. I'm also talking about data that enables public oversight of our governments and how they are enacting the national principles that reflect our shared values. Governments must stop shifting the blame and take full responsibility for the care endeavor. Finally, and most importantly, we must stop commodifying care. This means shifting from a transactional, rushed, and task-based care regime towards funding a more relational care model. So one that involves nursing, carers and PSWs, therapists, dietary, housekeeping, and laundry staff in innovation and learning together. This is what I've observed at the best homes, where even the housekeepers are empowered to sit down and play a game of cards with a resident. These are homes that resist ageist attitudes and that don't undervalue workers either. Mediocrity should not be the bar we set for quality care and decent work in long-term care. Residents and their families deserve relational care, and care workers deserve good working conditions. These conditions include, but are not limited to, sufficient staffing levels, permanent work, extended benefits, a living wage, a sufficient supply of resources to protect residents and themselves, and a job that should bring personal satisfaction and minimize poor health outcomes. Truly, COVID may have created a watershed moment and set our sights on making things better, but we will be worse off as a country if we do not take the chance to put our values front and center in a new set of national principles for seniors care that acknowledge our shared risk and that involve federal funding. We will be worse off if, in response to the pandemic, we overly medicalized and focused only on risk and safety, but ignored life and living with laughter, fun, good food, hugs, dignity, and joy. We will be worse off if we fail to set up a data accountability regime that also uses social sciences and humanities ways of knowing and assessing. And finally, we will be worse off if we continue to commodify the care of residents and the care workers themselves. Thank you.
Thank you, Tamara. André?
Well, thank you. I want to start by saying what a great honor it is to be on a panel with Dr. Daly and Dr. Sinha, two so knowledgeable researchers and clinicians. So I'll try and be brief because I'm really looking forward to the conversation. So I want to say that, I want to start by saying there are really no words to express just how horrific what has happened in long-term care has been. There have been almost 25,000 COVID deaths in Canada, but more than 17,000 of these have been in these institutional settings, mostly nursing homes and to a lesser extent, retirement homes. So we can't overstate just how grave the situation has been and how desperate it is to fix it. As you've heard and you'll hear over and over, these are long-standing problems, and they created the perfect storm for the ravaging of these homes by a virus. This should have never happened. all of this was preventable, and that makes it doubly tragic. Even worse than the death numbers is how people died. They died often alone, abandoned. Some people died of simple things like starvation, dehydration. All of these things are just unworthy of a country like Canada. Now, I want to say too that while we're talking about long-term care, we can't fix this in isolation. We have to fix elder care more broadly. That means finding the right care at the right place at the right time for everyone, ensuring there's good primary care, home care, decent community supports, etc. All of this is a continuum, and if we fix something in isolation, if we just build more beds, that is not the solution. In fact, I think it's maybe the worst case scenario would be just building more beds, because as Dr. Daly said, we don't need more mediocre care, we need better care, and we need fundamental reforms. Now, one of the questions we were asked to address is, do we have hope? Do we have hope that this can change? And I waver back and forth on this, being hopeful or not, depending on the day. I think there are little glimmers of hope. We saw in the federal budget $3 billion with a B allocated to the creation of standards of care. That's a good starting point. We really need standards. But then we saw the release of the Long-Term Care Commission in Ontario, a good report, nothing new. It told us what many, many reports have said before, but the silence of the provincial government in response in Ontario was very telling. And that silence for many years, that neglectful silence, has been deadly. And we can't allow that to continue. So that inaction, that lack of response is very, very troubling, and it should be troubling for families across the country, not just in Ontario. Now, what does give me hope? What gives me hope is that we know what the problems are. We know them very well. There's been more than 150 reports published on what's wrong with this sector and how to fix it. So we know everything. We know all the problems. We know all the solutions. Again, as Dr. Daly said, we have a lot of good care in this country, but it shouldn't be delivered in spite of the system. We should make it easier to scale up these good homes, to scale up the good home care, etc. And all the solutions exist. We just have to tap into them, and we have to stop repeating our mistakes over and over again. One of the biggest impediments to this, we always say, is money. People say, well, is this affordable? There's so much to do. There's a tsunami of elders coming. All of this is too costly. Well, first of all, I want to say we shouldn't catastrophize aging. This is wonderful. It's wonderful that people are living into their 80s and 90s and hundreds, and most of them are living well. And we have to ensure that they all live well, that they have quality of life. So this is a good thing. Let's stop saying that aging is bad. Now, is it affordable? Can we afford this? My answer to that question is always the same. Can we afford not to do it? Can we afford to continue to throw our elders overboard, neglect them systematically the way we've been doing? I don't think we can, in good conscience, continue to do that. Finally, I'll say, I think we have good values in Canada. We believe in fairness. We believe in equity. We have a Medicare system that's based on the principle that no one should be denied care because of an inability to pay. We have to extend that philosophy, we have to extend those values to other sectors, to long-term care. It can't just be about acute care. So I think in summary, in closing, I'll just say, what do we have to do? We have to give life to our values. I think we can do that. A reckoning is in order, and a reckoning is overdue, but let's do what we believe. We all love individually our grandmothers, our mothers, our grandparents, our great-grandparents, and let's give them the care that we want individually. Let's do that, and let's deliver it collectively. So again, thanks for the invitation here, and I look forward to the discussion and your questions.
Thank you, André. Dr. Sinha.
Thank you very much. Again, a real honor to be here today and with two very respected colleagues and to really talk about an issue that we're obviously clearly passionate about, but how do we point a path forward, and how do you bring hope in a very terrible year and a situation that really, I think, if it did one thing really well, is it raised the conscience of most Canadians now to understanding the challenges that we have in our long-term care system and the work that lies ahead of us. You know, I always take a historical approach when I think about how did we get into the situation in the first place, because when we look around the world, there are other countries that are doing much better on this file, that didn't actually see the devastation that we have seen, and partly because they actually have a well-funded, well-organized system of long-term care as a part of an overall elder care system that allowed them not only to provide good overall care before the pandemic, but also weather through it quite well. Because when you actually look at how Canada sits in comparison to the rest of the world, you know, amongst the G20 countries, if you will, we actually had the highest percentage of our deaths occurring in our long-term care settings. And that wasn't a fluke. That was the fact that our system was unprepared to begin with, and we were slow to respond as a country, and in certain jurisdictions in terms of how we could. And I think it reflects a number of issues. I think if you go back to when we created the Canada, or what we call Medicare in Canada, at that time, the average Canadian was only 27 years of age. Most of us didn't live beyond our 60s, if you will. So we can imagine why Medicare at that time really consisted of physician services, hospital-based services. We never thought about long-term care, possibly because we thought we would never age. And that's something that we've done incredibly well. We've almost doubled our life expectancy over the last 50 years. And as Andre said, this is, you know, we shouldn't look at this as using terms like tsunami. We should think of this as a triumph, you know, that we never thought we would age. We have in fact aged, and we will continue to age. And now we have older Canadians outnumbering younger Canadians, over 9 million people over the age of 60 in our society. That's more people over 60 than people who vote for any of the 3 major political parties in Ottawa. So this is a growing demographic, and soon by 2030, 1 in 4 of us will be an older Canadian. So that gives me hope, because frankly, this is a generation that, as they've continually aged our baby boomer population, they're ones that have demanded appropriate change and making sure that we have services that make sense. Because when you actually look at Canada in a global context, for example, not only did we eclipse, all other countries in terms of the percentage of our deaths that occurred in long-term care settings, for example, but we also know that Canada is an outlier when it comes to how we spend on elder care in general. If we think about long-term care as a continuum from home and community care to care in long-term care homes, for example. And that's because right now we spend about 30% less than the average OECD country on the provision of this sort of care. And the majority of what we actually spend overall is spent on institutionalizing people in long-term care or institutional settings, and not necessarily providing them the support to care for them in their own home. These are policy decisions that we have made. These are policy decisions that we enable. And back to what Andre said was, when people say, can we afford to spend more? Well, the problem, we could, we should have spent more appropriately, because when you spend that money properly, you actually save a lot of money down the road. Because right now, if you just project, if we continue doing what we're currently doing, we're going to need to find $71 billion to meet the needs of our aging population by 2050. That will represent 1 in 4 income tax dollars that we are bringing in by that time. And if we think that, well, we're not going to spend the money, we'll just get families to pick up the slack, as we often do, because families often provide 90% of the unpaid care in our society. Here's the challenge. With the declining birth rate, we're going to have 1/3 less available family caregivers available by 2050. And that means any remaining family caregivers that are available for free are going to have to improve their productivity by 40%. And then when you think about it, 1 in 3 working Canadians today is actually a family caregiver as well. So they're balancing paid work with unpaid care. And this really becomes not just an issue about elder care, but about economic productivity, the sustainability, and the well-being of our economy. And so can we afford to ignore this issue? Not really. If we're a just society, if we want to think about how we need to move this forward, we have to think about what underlies our values and what we need to move forward. And so one of the things that I think underlies a lot of this is systemic ageism. It was very upsetting for me to hear comments from, I remember one premier remarking in Alberta, you know who that premier is, who basically said, well, the average Albertan who's dying is actually 2 years older than the average life expectancy of an Albertan. It was a statement, but it's a statement that is very value laden because it's almost looking at, it's a tragedy what's happened. It's a tragedy that over 15,000 Canadians have died in these settings, and that 95% of the people who died of COVID to date in Canada are older adults. But, you know, I always wonder if this was a virus like the Spanish influenza that really went after children, would we have treated this completely differently, and how would we have reacted differently? So as Dr. Daly and as Andre have said, we know what we need to do. And I think, frankly, you know, we have many compelling reasons why we should do this. And we know what we need to do. We need to better fund our system, number one, but we need to put that funding in the right places. And we need to make sure, as Dr. Daly is saying, that this is underlined with appropriate principles, appropriate standards. Because frankly, if we do that well, we can all look forward to aging, unlike the majority of Canadians who now today are fearful because they're worried they might end up in a long-term care home and they might end up receiving mediocre care. And that's not a way to look forward to, you know, getting old in Canada. And it's something that we certainly have the power to change. So I'll stop there and look forward to our conversation ahead.
Thank you, Samir. Tamara, you spoke about national principles. I mean, you know, the whole notion of the need for norms, standards. I mean, the federal government has indicated it wants to work with the provinces on agreeing on some national standards. And in your forthcoming article in Policy Options, you make the distinction between national principles and national standards. Do you want to elaborate a little bit on that?
Yeah, I think if we think about principles as at the level of values, the sorts of things that we want to make sure that we hold our governments to account for, because it's the government that is often the one that is shifting blame in this system. They're pushing it down to providers, they're pushing it down to frontline workers, they're pushing it down to families. So if we have values that we collectively can agree that these are the sorts of things that we value, then we can say to policymakers, it is your responsibility to produce a system that respects these values. Standards can be about the ways in which we expect facilities and operators to provide care and the sorts of things that need to be to exist within facilities in order for the care to be safe, in order for it to be good quality care, for staffing ratios to be sufficient. Yeah, so that's where I would see sort of the difference between the two.
Dr. Sinha, you've been chosen to lead a committee of the Health Standards Organization to look at improvements in the standards on safety, quality of care, infection control. I mean, can you tell us a little bit about that process, and is that part of the solution? You know, isn't enforcing existing standard also part of the problem? You know, and one of the points that Tamara is making is that sometimes, you know, if you have the wrong standard or standards that have unintended consequences that in the end do not give you the outcomes that you need in terms of quality of care, it may complicate things. I don't know if you have some comments on that.
Yeah, no, it's a very good point, because I think, again, we need to rethink how we think elder care in general. Like, how do we think about the future of aging? And I think there are a number of different tools that we can do that. You can have the standards and you can have the principles in line, but if you're not actually going to fund that stuff adequately, for example, you're setting everything up to fail. For example, like right now, we have a standard that's been agreed upon in Ontario that we should be providing at least 4 hours of care per day. But right now, our provincial government that funds all of our publicly funded long-term care, regardless of whoever operates it, whether it be a for-profit or a not-for-profit municipal home, they only get funded to provide 2 hours and 45 minutes of care per day, even though the government stated standard is to be providing funding for 4 hours. They've agreed to reach that. Now, they said they're going to reach that funding by 2025. I don't know why we can't do that sooner, for example. But then all of a sudden, you're already setting up a system to fail, even though we haven't agreed upon standard. So again, when we start thinking about how do we rethink elder care, we have to think of it in a number of different tactics. You know, I agree with Dr. Daly is that the idea of principles, right? What are those principles? When I was tasked with developing an Ontario senior strategy, and I've done work in partnership with the IRPP and others around a national senior strategy, we've talked about 5 principles. And I'm not saying these are the exact principles that that, that might be the same ones we're thinking about for long-term care. But for a senior strategy, we talked about access, equity, quality, value, and choice. These principles underline how we think about needs for seniors and thinking about those important principles. So that's a concept that we really thought about. When you think about standards, I think a lot of people aren't even aware about, what standards, what are the roles of standards and what they can or cannot do. And are they the be all and end all? They're not the be all and end all. First of all, we have standards in Canada. There's a whole standards process. There's standards for everything. So every hospital in Canada, for example, is following a national standard for hospital care that's developed by HSO, for example. And some people would argue that that standard has been really helpful as the basis of accreditation in other ways to kind of set the standard that people can expect. And generally, when people go into hospitals in Canada or see how hospitals are performing during this pandemic, they'll say they're doing quite well. But I would also arguably tell you that hospitals are much more generously funded, than our long-term care system is. Because I was talking to a registered practical nurse the other day who said that her part-time job at a hospital in Toronto pays her $31 as an RPN, but for her work in a local long-term care home where she works full-time, she's paid $4 an hour less. So the same people doing essentially the same work are paid far less in another part of the same publicly funded healthcare system. So again, you could have a great standard, but if you don't fund that care properly, then how will that standard move things forward? So the work that I've been tasked to do is part of this broader work about looking at what are the sorts of standards that can be enablers to improving long-term care in Canada. And broadly speaking, there is a national standard for long-term care that exists, for example. It has been the basis of accreditation in about 60% of homes across Canada, 100% of the homes in Quebec, for example, pretty much all the publicly funded homes beyond Ontario, for example, and BC across Canada. And the key is that these are standards that exist, for example, and there's an opportunity to look at how we can look at those standards in light of COVID and say, are these good? Are they adequate? Or what are they missing? There's an opportunity to revisit these completely and start again from the ground up and say, what does this care need to look like? And how can this be enabling? At the same time, we've recognized we don't actually have any national standards around what the facility itself, what a building should look like. Looking at certain principles like how we operate a home, how we think about things like ventilation systems, HVAC, and that's where CSA has also stepped up and said that we will help develop those standards. And that's actually under the auspices of the Standards Council of Canada, which is a Crown agency that oversees all the development of standards. But at the end of the day, whatever standards we come up by 2022, it's great that the federal government has said there'll be $3 billion to help provinces and territories implement, these standards that we come up with, that we engage the public in and do. But at the end of the day, it's really going to come down to what the provinces and territories that oversee the jurisdiction of long-term care. And again, if Ontario still says, right, 4 hours of care a day, and we're only funding 2 hours and 45 minutes, or we're not going to fund infrastructure development to go to that standard or whatever the case is, we're not really going to move the bar forward. So standards can be enablers. Standards can be the basis of legislation. They can be the basis of accreditation, enforcement, regulation. But again, it's standard is a standard. It's how we actually use that standard to really allow us to deliver better care. Same with principles, is how we're actually, if we enable those principles and those standards, then we're really going to hit the mark of what we want to achieve.
Thank you. André, you spoke a lot in your book about this issue, and when we got, questions prior to this event from some of the participants asking, why were structural standards so poor, staffing levels so low, training so inadequate, supervision so lax? Is that was part of your diagnostic, and I don't know, what your views are on the solution to this.
Yeah, so I think a lot of it is what we've heard in the presentations, that there's this ageism is ingrained to our public policies. So we don't have the same expectations of long-term care homes as we do of other parts of society, like hospitals. I often use the parallel of, if this had happened in childcare centers, in daycare, the public they'd be marching on Parliament Hill with pitchforks, if children were treated the way we treat our elders. Now, I'm hesitant to use that comparison because it sounds like infantilizing, but it just tells us that some groups in society are less important. So I think that's the fundamental issue, is we just haven't valued people when they get older. When you stop earning an income in our society, you stop being of value, and we shunt you off to these institutions. So I think there's that fundamental issue. Then there's what we've heard from the other two panelists in much more detail that I can provide, just how we don't necessarily measure the right things, right? So I think that we have all kinds of rules now. I remember visiting a long-term care home in Ontario, and they had 91 pages of things that they had to do. They showed me, here's the things, here are the rules. We don't lack rules, but we don't, not a single one of those things in 91 pages measured the quality of life of residents. We kind of forget that there are people living there and they have lives. So it's not just about measuring, it's about what we measure, and it's about doing something if people don't live up to the standards we set. So which nothing ever happens, if you break the rules, etc. What happens to a home? Nothing really. We don't have any enforcement to speak of. There's very little inspection. I talk in my book about how we have more, in Quebec, for example, more inspectors to making sure people are taking care of their pets than taking care of elders in institutional care. There's many more people working in animal welfare than in inspection of homes. So that's just an example of, again, what we value in society.
Tamara, you talk about the commodification of care. Why stopping that is so important to improving quality in long-term care. Can you elaborate a bit on that?
Yeah, I think when we're really just trying to think about care as a task, then we think about it as a very, very specific service that gets delivered in a very specific amount of time. And, we're rushing to get those tasks done. And I think here a lot about the Nordic countries, or even in some of the homes that I've been in Australia, where they're a lot more flexible around meal times, and they don't count activity in the same way. They sort of see, they give more leverage and leeway to care workers to develop relationships with residents. So if we move away from something that's highly task oriented, where you can count every single, like it's a kind of more of a ticky box mentality, right? It's like, I did this, and I did this, and there's a specific time for this, a specific time for that, and a specific time for this. And you move it more in the direction of thinking about someone as an individual who needs individualized care and they need personal attention, then you can think about how to provide services and wrap services and wrap supports around that person in a way that moves it away from a transaction and towards a relationship. And that's what I think I'm trying to get at when I talk about getting rid of commodification and this idea of care as a commodity. And it's also, when you think about commodities, you want to lower your costs, right? So if we don't commodify our workers, we won't have the sense that we have to pay them so very little and not provide them with decent working conditions, and the sorts of things, the sorts of supports that we need are required in order for people to have good working conditions.
Thank you. One of the issues that comes up again and again in some of the questions and in the public debate, of course, is the role of profit long-term care in our system. And I'd like to hear your views on that. I mean, there's some people that think we just sort of should eliminate that because, right off the bat, if you're providing care on a profit motivation, that it is impossible to get to the type of quality of care that you want, but not everyone agrees on that. Maybe we'll start with Dr. Sinha.
Yeah, no, I mean, it's an excellent point, because I think, we're having this whole conversation about, what is the role of for-profit provision or ownership, and why do we have this? Why is it 1 in 4 homes in Canada, for example, is owned by a for-profit operator, for example, when I don't know of any publicly funded hospital, for example, in Canada, that is owned by, if you will, a for-profit operator. I mean, there's some very small exceptions, to that, but we have a publicly funded hospital system. If any, level that we've allowed for-profit kind of involvement in, it might be around the building of the facility capacity or the contracting of some services, whereas we've actually allowed for-profit ownership into the space of homes. And I think partly it comes down to, again, our values and our funding. And frankly, this is an area that we underfund by 30%. Again, if you look at around the world, we don't really fund the system adequately. And I think back to what Dr. Daly was talking about, like this commodification, for example, when we now reduce kind of just the overall act of care to something that we just say, well, how can we do this cheaper? Well, now if we actually have for-profit owners, for example, that can run the care, for example, that we incentivize them to get involved, to maybe shift infrastructure costs, do other sorts of things, maybe in some way that's a way to cheapen this entire expense that we really don't care to provide in the first place and what we do. Because the overall challenge is this, is that, why do we have this whole system where we have 1 in 4 homes in Canada, which is owned by a for-profit provider, but we haven't done that around hospital care. And I think a lot of it comes down to the fact that we're just not funding a system adequately. We're using this kind of as a mechanism. And then when you have for-profit providers involved, there are some incredibly great for-profit providers of care. But I think overall in this pandemic, there's been a real focus on a lot of for-profit providers where the outbreaks have been deadlier, that the outcomes have been worse. And in generally, when you look at the literature, it's really hard to maintain, a good standard of care overall in an underfunded system, and then also try to please your shareholders at the same time. It's a near impossible task to do well, especially when we're dealing with frail and vulnerable older people. So, I think, the challenge here, when people say, well, we just need to remove all for-profit involvement into long-term care, like we could do that, right? Like we could do that. And people say, oh, for $1 billion or $2, we could get that done. And we've got this 5-point plan. Well, I've looked at some of the political plans to do this, and we could do this, but we're going to have to find at least $12 billion in Ontario to buy back all these homes, to buy back the property, to redevelop these homes, which are often older, to do that. And then the fact is we're still dealing with a system that right now only gives, whether you're a publicly owned or a privately owned home, 2 hours and 45 minutes a day of funding when that home needs at least 4 hours a day. And the reason why our municipal homes and our not-for-profit homes do much better in Ontario, provide better quality care, is frankly, I sit with the City of Toronto Senior Strategy. We supplement our long-term care budget that we get from the Ontario government by $24 million extra a year from property tax revenue. Our charitable homes in Ontario put an additional $300 million a year on top of what the provincial government does to provide what they think is reasonable quality care. So this is where, again, there's a lot of ideology in this space, but I think the first and foremost thing that we can do if we want action tomorrow is, number one, just fund the system adequately to begin with. And then I think the key is, really evaluate the role of, is there a really good reason why we need to have for-profit involvement? And if we do have that reason, well, then let's make sense of that. But I think the problem is we've got, the deeper issue is that we just grossly underfund the system. And then we're using the for-profit models as ways to try and, make it easier and less expensive to do something that we don't want to do in the first place, which is provide good, high quality care to older Canadians.
André?
I think Dr. Sinha touched on all the big issues. I would just say, I just worry that people hold this out as a panacea. Ownership matters, but to me, it's about number 20 on the list of things that are important at this point to fix. I thought the Long-Term Care Commission in Ontario did a really good job of tackling this issue, saying, what we need is to not have real estate developers delivering care. So we have to ensure that all the care is delivered in a not-for-profit fashion. That's what's important. Who builds the buildings? It doesn't matter to me. I don't think it should matter to anyone. We have to separate those two functions. I think we also have to be careful that private care is not always these huge multinational corporations. There's a lot of wonderful family-owned homes that are technically private. So let's, if we're going to deal with this issue, let's deal with the real issue, which is, as Dr. Sinha said very eloquently, it's the delivery of care. Make sure that we spend adequately and properly and that we take the profit out of care. But buildings, I don't care who builds them. I don't think anyone does, like highways, like hospitals, they're all built by the private sector, but get those people out of the delivery of care business. and focus on the real estate part. That's something else. So get the hedge funds out of there, I call them slum landlords in my book, get them out of the sector and let caregivers care for people. That's what we need.
Tamara.
You know, what I find very interesting about the question around profit is that we never seem to want to take a whole of system approach when this question comes up. So what often happens is we see at an aggregate level that the care outcomes associated with for-profit provision tend to be lower than if you would find in a nonprofit or in a public home. And Dr. Sinha is quite correct that the care levels are supplemented by additional funding, but we also know that residents are more often quickly transferred to hospitals out of for-profit facilities because there's higher proportions of understaffing, there's much more staff turnover, there's staff that are paid a lot lower, a lot more agency staff are relied upon. The other thing I think we have to think about this notion of what is care. Care is not simply PSW and nursing care. It involves dietary, it involves laundry, it involves housekeeping, it involves maintenance, and it involves management. And what we see increasingly in places like Ontario and in other states in the United States, and we see it in other countries as well, is that we're hiving off these different parts of the business. And so there, where we see this, we actually get a more transactional and commodified frontline care, because those care workers who are doing nursing and personal care work are kind of jumping to the beat of the drum of other care workers that are contracted out. And there's not the sort of synergies that you'd expect from workers who are working for the same organization. So I'm really hesitant about this notion of who cares who builds the building, who cares who do this. I actually think we need to have a really good and honest conversation. The other thing that I would suggest is show me the data. Public funds, then I don't want there to be proprietary and private data. I want data transparency, I want data accountability, and I want the for-profit providers that are absolutely excellent, I want them to shine because they're innovators and they deserve respect. But I want the bad apples to also be revealed. And if the bad apples are driving the aggregate level poor health outcomes that some of the best for-profit providers are having to put up with, then it's also in their interest to want this level of data transparency. Because if they truly are the innovators that they claim, then they would have no problem with us revealing the ways in which they are absolute leaders. So I think that all of these things are really, really important. And quite frankly, I'm not really happy with the idea of throwing a whole bunch of public money at a system without this level of accountability. I think that a lot of organizations who, while the returns, we're not really clear on how organizations make profit. They make lots of claims about how they make profit and how they're limited, and it's not really a great place to make profit, but I'd really like for the books to be open. I'd like to see the contracts that they make with food service providers and with housekeeping companies and how many agency workers that they have. I'd like to see how many workers that they're able to retain and what the job satisfaction is of workers that work there. I think all of these outcomes are due, and they're the way in which we ensure that this system gets better. We know that without good data, we are not going to make the sorts of improvements that we need to make.
Yes. I'm gonna segue to another topic, a topic that's coming up in a lot of our questions here. André, in your book, you argue home care is grossly underutilized and underfunded, despite the fact that aging at home is the absolute preference of elders. And we're getting a lot of comments in that vein. So I'd like to hear each of you on that. Maybe we'll start with André because I started with your book here, but I'd like to know about the role of home care in all of this.
I think part of it comes down to these values, and one of them, as Dr. Sinha said, is people should have choice about where they live their lives, how they live it. Now, that can't be unlimited, but we can, I think, for the same price or slightly more, provide a lot more home care. So I think what question we have to ask, and we don't have the best data, but what percentage of people in institutional care could now be cared for at home? We know it's a significant percentage, 20, 30%, whatever. So it's a large number. They live differently. I find a lot of people end up being funneled to these institutions for really banal reasons. They can't shop for their groceries anymore. They've can't shovel the walk, etc. So we can do these, we can fix these things with better community services, by providing more subsidized housing, by bringing care to people in these NORCs, naturally occurring retirement communities, bring services to them instead of picking them off and sending them to homes. So I think we have to think about, as I said in my opening remarks, what's the right place to deliver care to people at that moment? And we have to make it a continuum. And when people do need to go to long-term care, and I'm not saying in any way we don't need it, we absolutely need long-term care, but it should only be people who need the 24/7 care, and it should be in a more home-like setting. It shouldn't be in these prison-like facilities, which a lot of our homes look like. So I think home care has a really important role in allowing people to stay in the community, and being part of the community, I think should be an essential value we have. So to me, that a lot of what we need to do is not just have programs, but have this philosophical change. If I look at the countries that have good elder care in the country, like Denmark and Norway, that's the big difference, is they say, we value elders, we want them in the community, and we're going to do whatever we can to keep them there until it's no longer possible. And we have the opposite. Let's get them out of society. We essentially practice elder apartheid in Canada. When you get a little bit rickety, off you go, get you out of society, never to be seen again. I think we should see people who are old, we should see people with dementia every day in our everyday lives, and we should make society more able for them to live in mainstream society.
And you're totally right about this change of mindset, because when you compare the cost of places in long-term care, institutional care, versus what it might cost to provide decent home care, it seems that if we did the cost benefit analysis of that, the calculus would be very different than what we end up with now. Dr. Sinha.
Yeah, so one of the policy reports that I put out in November was actually a full briefing note I presented to the Ministers of Health and Long-Term Care a year before, in the fall of 2019. It was this notion of virtual long-term care, because, to Andre's point about what percentage of people are we actually putting into homes who probably could stay in the community, it's about up to 1 in 3. So if you start thinking of that, wow, we're putting a lot of people into these homes, and homes cost money to build, right? When you're actually building a brand new home, every bed is about $250,000 of infrastructure dollars. But imagine, if you actually care for people in their own homes, if they're lucky enough to have one with their own bed, if you bring the care to them, you can often do a heck of a lot to support them, even at the amount that we pay for the care envelope of what actually happens in a care home. So there's a lot of opportunities to think about that way. But let's go to Andre's point about Denmark. Denmark spends twice what Canada spends of its GDP on the provision of care for older people. So we spend about 1.3%. The OECD average is 1.7. Denmark spends about 2.5%. We spend 87 cents on every publicly funded dollar for home care and long-term care. 87 cents on every dollar is around institutionalizing people in long-term care homes. Denmark spends 2/3, about 66%, caring for people in their own home first, and 1/3 of that money goes towards caring for people in long-term care homes. So as Andre was saying, you're not going to get rid of long-term care homes, nor should we. There is a role for them, and we want to make sure it's providing good, high-quality care. But by actually shifting this entire focus about being more about keeping people at home where they want to be, and those stats you were showing from another report that our NIA put out earlier this year, showing that the overwhelming number of older Canadians want to stay in their homes for as long as possible, we could actually enable that for not a whole lot of extra money to support people to stay in their own homes for a little bit longer. It improves our capacity for what we're doing in our long-term care system, and it's actually a much more cost-effective way to approach elder care, and it also gets to give people what they actually want and need. So I always kind of say to the arguments we're making here, it's one of those rare policy opportunities where what we're proposing to support people more in their homes is actually something that can save us money. and deliver better overall outcomes as well. So, you know, it's an opportunity that we shouldn't pass up, especially as we continue to age. But, you know, I think people are worried right now that there's so much focus on fixing long-term care. People are forgetting the value of what home care can do, and how, you know, home care really can actually is something that has, if we're thinking long-term care has been neglected, oh my goodness, you know, home care has been far more neglected as well.
Tamara?
Well, exercising choice in late life is really important. We also have to think about the choices that are available to family and those who are providing unpaid care work, most of whom are women, who are doing the majority of that care work and that care coordination. And so if we're thinking about systems that are equitable, we need to think about gender equity in this conversation as well. And when we're talking about it costs less, my question is, it costs less for whom? Who is taking the burden of this cost? Are these costs that are borne unevenly by women in our society? Are these costs that are borne unevenly by particular groups in our society? I think having excellent home care and excellent community support services are absolutely foundational to a system of seniors care. These things go together. You can't, in some ways, have one without the other. But I would argue that while the person that we are looking at and their clinical indicators might give us the idea that they could otherwise be cared for at home, getting home care requires a lot of supports that are invisible. And unless we make those other supports visible, we're kind of fooling ourselves that these costs aren't being borne by someone somewhere and under some conditions. And I think at the end of the day, high quality long-term care provides dignity and respect to people that need that care, as well as those who are providing the essential care, who are family, friends, and neighbors, and kin or not kin. So we need to think of this again in terms of like a broader approach that includes the other people that are part of that person's care constellation.
Mm-hmm. We're starting to run short on time. One last topic I'd like to address before we wrap up is the topic of human resources. You know, as we've seen in the pandemic, a lot of the difficulties we faced were about understaffing, and there's the issues of training, having the right human resources at the right place at the right time, the right allocation of professional support. So I quickly, if you could just each give me your, like, how do we tackle that problem? Where do we start? And I'll start with André.
I think we start by realizing, first of all, that healthcare is all about people caring for people. So this has to be the essential. I think this, the starting point of reforming has to be about making sure we have adequate care, whether it's in home care or facilities or in community services. So it's all about people. One way to do that is with the standards of care, and the standards of care debate is largely at this point about that. It's about, can we provide minimum 4 hours of hands-on care, et cetera. So I think it is all about people and ensuring we have an adequate number of people. You know, we saw Quebec hire 10,000 personal support workers, and that's just the beginning. We're realizing the pandemic has made us realize that we're chronically understaffed in homes as well as in home care. 80% of shifts were were not complete before the pandemic. I shudder to think what it was in the pandemic, because I don't think there was ever full staffing in any homes during the pandemic in much of the country because of the impact on the staff. So that it begins with staffing. There's no question, all the reforms.
Dr. Sinha?
Yeah, just building on that. I mean, I think when we think about human resources, I think of two groups: staff and then families. When we think about staffing, I've been using the example of Ontario. To go from the 2 hours and 45 minutes a day that we're providing to 4 hours a day by 2025, the government estimates they need 27,000 more workers. Those are 27,000 workers that are currently missing from our system, and that's PSWs, that's RPNs, that's RNs, for example. So it's a lot of people. hospital. But the key is, if you pay them poorly and you don't treat them well and you don't give them the right educations and supports, they're not going to last very long. And one of the challenges we have in Ontario is, again, I was talking to an RPN the other day. You know, she will get paid $5 more an hour if she works at a hospital. She'll get paid $5 an hour less if she works in home and community care. And as far as I'm concerned, we should have wage parity, because otherwise we create this kind of system of apartheid by wages. The further you walk away from a hospital, the less you get paid. I had a great PSW who came with a patient the other day, and what did they say to me at the end of the appointment? Dr. Sinha, you know, I'll stay with this patient until they die, but, you know, after that, could you put in a word to get me a job as a cleaner at your hospital? Because it pays better than what they do as an outstanding personal support worker. So we have to think about the workers and how we better treat them, making sure that they're not working in understaffed and poorly paid. And then finally, I think one of the things that the pandemic really brought out was this whole invisible group of caregivers, the families, especially in long-term care settings, because when we shut them out at the very beginning of the pandemic, and we still continue to you know, keep them locked out of the homes in some cases, for example, they provided a huge amount of invisible care. And I know Dr. Daly is working on research around this as well, but we started realizing that without them and without supporting them and recognizing them as essential family caregivers or essential visitors, we were doing both the residents a disservice and also the staff who frankly needed those families. Otherwise, their lives were even more miserable to begin with. So that's what I think about the human resources challenge, and again, the opportunities to get that right moving forward.
Tamara.
So we often like to say that time to care is one of the key elements that describes how good care happens. And an awful lot of people have talked about training, but I'd also like to kind of posit this, that if you simply have too few people available to provide good empathic care, you're going to get rushed care that is poor care. But if you have sufficient staffing, that means enough time to actually spend good relational time with people and do things in a way that's personalized and individualized, then you're going to get better outcomes overall. These are both social care outcomes as well as healthcare outcomes. So the sufficiency of the staff, I would put at a much higher level than even the kind of training or new training, because there's so much emphasis that we have a workforce that needs training. Actually, we have a workforce that's highly skilled and that really does know an awful lot. And we need to better value their skills and understand what it is that they do, because they know what it takes to provide good care. They're just not given the opportunity to do it. So we need to make sure that our governments give them the opportunity to do the type of work that they went into this sector in order to do, and that they get the job satisfaction that is required so that they stay in this work, because they are the absolute backbone of these systems. So I'll leave it there.
So we're going to have to wrap up. What I'd like to do is, you know, short closing remarks from each of you, and one question that has come throughout this webinar is the words political will. Where is the political will going to come from? Where's the leadership going to come from to commit to change and to follow through with the necessary resources? So I'd like to hear your closing thoughts on this, even though we could talk about this for hours more. Dr. Sinha.
I think the political will come from our elders themselves. I think the one great thing that comes with age is wisdom. I think our older people know what they want. They know what we need to do, and they're motivated. And so I'm looking forward to the idea that if all seniors got together today and became their own political party, they would outnumber any political party in Canada in terms of the number of the votes they've received. And with an election this fall, we could get a lot of that wisdom harnessed to fix a lot of the issues we talked about today, and more so. So I think the political will come from our society itself, because I'm not waiting for the politicians to get this right.
André.
Yeah, I think, you know, we know the problems, we know the solutions. The only thing missing in the equation is the political will. So how do we inspire that? I think it's, as Dr. Sinha said, elders have to use their political clout to vote. I think all of it's incumbent on all of us to say that this is important, that every one of us values our loved ones, and we want that for collectively as well as individually. And finally, I'll say one of the most uplifting things for me when I've been promoting my book is the interest of younger people in this issue. So many young people saying, it sickens me the way my grandmother is treated. I don't want to be there. I don't want to be treated like that. Everyone who doesn't want to be treated like that has an obligation to say, politicians have to act. If we all agree across the age spectrum, it'll get done. Politicians will have no choice but to act.
Thank you. Tamara.
I get the last word here. That's fun. I actually think long-term care has always been a place where there's diffuse interests, and then the folks who are going through it, the family members and the residents, they are often so overwhelmed that they don't have the opportunity to see that other people are paying attention. Well, COVID shamed us all in Canada, and shame on us even more if we look away at this point. I think it's really important that we just not let our foot off the gas. You've talked about a roadmap. I think that this is a trip that we are all on together. And if we look out 5 years from now and nothing has changed, shame on us even more.
Thank you. I want to thank all three of you for your great insights and your generosity, and I'm sure people really appreciated hearing from you and at the beginning of this big conversation. And I want to thank all the participants for listening. And we have 225 questions, so obviously we could not get to many of them, but I just want to assure that our listeners that we will be sharing those comments and questions with the participants, because and for ourselves too, because it informs our research agenda going forward. And hearing the ideas and the concerns of Canadians out there is part of this process. Our next webinar on long-term care will be on May 20th, and it's on could federalism help cure what ails long-term care. You will receive a link via email about the webinar, and for those who want to listen to it again. And I remind you of our policy options series, which begins on Monday. So thank you again, and till we meet again, thank you. Goodbye.
Thank you to Tamara, André, and Samir, our panelists, and to our moderator, France. Thank you all for your participation, and stay tuned to our social channels for information about future IRPP webinars.